Morning, everyone. Welcome to the third and final day of the Healthcare Unscrambled conference. My name is Vera Salzburn, and it's such an honor to begin this day with you with this short wellness practice. So one time I saw a cartoon, a New Yorker cartoon, and it had a drawing of Buddhist monks protesting. And the protest signs said, "What do we want? Mindfulness. When do we want it? Now." So I would like to invite you to spend the next few minutes in a practice that helps us cultivate mindfulness as well as compassion and kindness. And this practice is called giving and receiving compassion. And it uses our breath for offering compassion and kindness to others, and also for receiving compassion and kindness for ourselves. So I know it's early in the day, so we're just settling in. So I invite you to maybe shift your body in a way that maybe you can feel a little bit more comfortable for the next few minutes. And you can simply rest your hands in your lap if you wish. And if you'd like, perhaps closing your eyes fully or partially. And just taking a few nice, deep, relaxing breaths. Just to let go of any unnecessary tension in your body. Just a nice deep breath in and a nice slow breath out. And now just letting your breathing find its natural rhythm. And perhaps continue feeling sensation of your breathing. Perhaps noticing how your in-breath nourishes your body and how your out-breath relaxes it. And now focusing your attention on your in-breath only, letting yourself savor the sensation of breathing in. And perhaps if you'd like, breathing in something good for yourself. Perhaps breathing in kindness or compassion, happiness, love, freedom, acceptance. So perhaps with each in-breath, just breathing in a word or an image or a quality of something good, something that you need right now. That's it. And now shifting your focus on your out breath and perhaps feeling your body breathing out, feeling how perhaps it relaxes. And now bring to mind a person or being. It could be your pet, even. Someone whom you really love, or perhaps someone who is struggling right now. And simply begin to direct your out breath to this person or being. And if you wish, sending with each out breath kindness or compassion, love, happiness to this person or being. And if you wish, you can breathe out to others in general rather than focusing on a single person. Very nice. And now focusing your attention both on your in-breath and your out-breath. And perhaps on your in-breath, breathing in something good for yourself. And on your out-breath, something good for another person. And perhaps even saying to yourself, in from me, out for you, or one for me and one for you. And feel free to make adjustments even if you need to breathe 2 for me, 1 for you, 1 for me and 3 for you. That's fine. And just letting go of any unnecessary effort and making this compassion practice as easy as simply breathing in and out. Simply allowing your breath to flow like an ocean. Waves coming in and waves coming out. Now letting go of any images, letting go of watching your breath, and just simply noticing how you're feeling right now. Noticing how your body is feeling, your emotions, your mind. And whenever you're ready, gently opening your eyes. Thank you so much for practicing this practice. Just remember, you can always offer someone something good just with your breath or with a thought or a smile. Okay, thank you. Have a good day.
Thank you, Vera, for leading us in that mental wellness moment. I think we're all increasingly aware of the importance of mindfulness and self-care, and especially compassion and kindness in these challenging times. Good morning. My name's Harry Hyman. I'm a member of the board of directors for Georgians for a Healthy Future. And it's my pleasure to welcome you to the final session of Healthcare 2021. And what a great way to start in getting grounded together in what hopefully will not only be a safe space for us, but an exciting place to learn together. The next slide, please. Here's this morning's agenda, just to give you an overview of what's ahead. And as you can see, we'll be sharing lots of important information, insights, and perspectives to share and learn from our experts in the field from across the state. The next slide, please. Needless to say, our work wouldn't be possible without financial support from our sponsors. Thank you to Pharma for supporting this morning's session, and thank you to the many individuals and organizations, including many of you here with us this morning. While we share thanks, please feel free to put your name, the city or town that you're zooming in from, and what you'd like to learn from this morning's session into chat. And if you don't see your name on the screen and you haven't had an opportunity to contribute to GHF, it's never too late, and we invite you to consider a donation. Needless to say, improving health outcomes, health opportunities, and health equity in our state has a long way to go, and we need everyone to partner with us in this critical work. Next slide, please. A few things to share with you before we get started. As you can see, GHF is currently hiring for 2 positions. So please consider joining our team or sharing this information with people you know who you think would be a good fit or may be interested. You can find more information on our employment opportunities page. Next. Our speakers will be using PowerPoint this morning. To have the best view of the speakers and their presentations, if you can find the attendee on your screen named GHF Main Program, click the 3 dots on the top right and select Pin. That will pin their slides to the center of your screen. And last, we will be using the breakout feature of Zoom. If you haven't used this feature before, the best thing to do is to sit back and let our partners at Spectrum Entertainment do the work. You don't need to do anything to either get to your breakout room or come back to the main room. We promise we won't leave you behind in cyberspace. It'll happen automatically, so please don't accidentally leave the meeting when you're in transit. and you'll have time for interactive discussions in your breakouts, but please mute your microphones while we're in the main room and when we return to the main room. Next slide. So it's now my pleasure to turn things over to Laura Colbert, GHF's Outstanding Executive Director. And again, thank you so much for joining us this morning.
Thank you so much, Harry. Good morning, everyone. It's really wonderful to be here with all of you. You know, we started our program about a week ago this Thursday, and it has been an action-packed 8 days in the country and in the world. And so we're just really pleased that all of you have chosen to spend some time with us this morning when there are about 1 million places to spend your time and energy. So thank you so much. And I think you will find that your time this morning is well worth it. We have a really great lineup of panelists who I imagine will be the highlight of your day. But before we dig into that conversation, what we'd like to do is present to you guys some data that we thought would be helpful in providing all of us with some shared knowledge and a shared starting point for the conversation this morning, which will really touch on incarcerated people, rural communities, mental health and substance use, and health access general, and racial equity. So we've got a lot to cover this morning, and we wanted to make sure we all started on the same foot. So this is, as you can see in front of you, and again, hopefully you've pinned that GHF program window so you can see the slides. But also Michelle has dropped the slide link into the chat so that you can see that as well, if that's preferable for you. But this morning we'll be talking a lot about rural communities, and you can see here that this is a map of the counties in Georgia that are considered rural. Our state's definition is counties with a population of fewer than 50,000 people, and about 120 of our 159 counties qualify and meet that standard. Next slide. And this morning you'll hear from 2 speakers from the Rural Black Women's Initiative, and their work focuses specifically on Baker, Coffee, and Wilcox counties. So we've circled those here on the map for you so you know how to find them. It might be good to kind of keep an eye on those as we run through this data. Next slide, please. We're also going to spend a lot of time talking about racial equity, and particularly Georgia's Black population. And so we wanted to highlight where we're talking about when we talk about Black communities, and especially majority Black counties. You can see here that in the darkest green counties, those have majority Black populations, and then also those kind of more moderate green counties still have a large proportion of their population is Black. And you can see here that a lot of these counties really overlap with the counties that are defined as rural. So when we talk about rural counties, we're often also talking about Black communities. Next slide, please. And because COVID is the most pressing health issue facing Georgia at this moment, we wanted to just remind everyone of kind of where we are in the pandemic right now. You can see here that, as of January 7th, when we pulled this data, these are the this is kind of the map of Georgia with the darkest counties having the highest rates of COVID-19 infections to date. Next slide. And these are the counties with the highest rates of COVID-19 deaths. And again, you can see a pattern forming here around those kind of Black Belt counties, as they're often called. Next slide. And on this map, I accidentally duplicated, or on this slide, I accidentally duplicated a map. So Michelle is going to drop the link to the accurate map in the chat for me. But the title of the slide kind of summarizes it, summarizes the point of the map well, in that adults, more adults in majority Black counties report fair or poor health than in other counties. So there's a higher rate of lower health status in those counties where there's a large Black population in Georgia. Next slide, please. And we see this consistent also in when it comes to mental health specifically. So we see a higher number of reported poor mental health days in counties that have larger Black populations. Next slide. This map is just a quick look at where our rural and critical access hospitals are in the state. And as many of you all know, this map is from August of 2020. And as many of you all know, in October, 2 hospitals in Jackson and Randolph counties closed. So this map is actually a little bit more generous about where those hospitals are located versus the reality on the ground today. Next slide. We will also be spending some time this morning digging into Georgia's criminal justice and corrections system. And so we wanted to also give you all a little bit of context for that conversation. We've got about 102 Georgians who are incarcerated across a spectrum of facilities. And this data is from 2018, but anywhere from federal to state to local incarceration settings, there's about 102 Georgians in those facilities. Next slide. And even following, you know, Georgia is often held up as kind of a state leader on criminal justice reforms efforts, but even after those efforts with Governor Deal, Georgia's incarceration rate really stands out when compared to our national incarceration rate, and also when compared internationally to other countries' rates. Next slide, please. And one thing that I think was well known before last year's racial justice uprisings, but has certainly been highlighted and discussed in more detail since then, is that there are huge racial disparities in the rates of incarceration across different race and ethnicity and ethnicities. And in Georgia, that holds true. Black Georgians are held at rates 17 points greater than their share of the population, and white Georgians are underrepresented by about 13 points. Next slide, please. And then we thought it would be helpful also to demonstrate kind of the variation in rates of prison admission by county. There's a big spectrum of rates across the state, and we do see higher rates in rural counties generally, but as you can see, you know, counties are really, some counties are really doing better than others at reducing their jailed and imprisoned populations. But there's a real mixed bag across the state with some, you know, some counties having pretty meaningful reductions and other counties seeing continued upticks in the number of folks who are in prison or in jail. Next slide, please. And of course, there's been a lot of discussion this year about, you know, the increased risk of COVID-19 in residential facilities, including incarceration settings. So folks who are in jails and prisons are at an increased risk of COVID-19 infection because of the tight living quarters and because many of them have pre-existing conditions at a higher rate than those in the general population. So we wanted to just give a quick glance at kind of the state of COVID-19 in Georgia's prison and jails. And you'll see this data again from one of our panelists, so you'll get to take a closer look at it. Next slide, please. And unfortunately, Georgia's COVID-19 response in incarceration settings and correction settings has been not great. The Prison Policy Initiative gave an overall grade of an F+ for our state's response. While there's been, you know, some effort to release people back to the community, many other really basic measures have not been pursued, including a mask mandate for folks who are working in incarceration settings, as well as the residents themselves. And so that kind of brings us to the end of that data, and hopefully that gives you a little bit of context for today's discussion. Again, The slides can be found on our digital program page, and Michelle has dropped that link into the chat if you guys want a clearer look at the slides. But what I'd like to do is go ahead and bring up our first presenter for this morning, Roberta Tony Myers-Douglas of the Legal Action Center. The Legal Action Center is actually based in New York, but Tony is a Georgia resident, so she lives and works here in the state with us, and she co-leads the Legal Action Center's No Health, No Justice initiative. She is an amazingly effective advocate for justice in the corrections and healthcare systems, and we're so pleased to have her here with us this morning. So Tony, welcome, and thank you for joining us today.
Good morning, everyone. I'm so happy to be here with you this morning, along with my cup of coffee. I hope you have yours. Legal Action Center is a nonprofit law and policy organization based in New York, Washington, D.C., and Georgia, where I reside, like Lorick said. We have existed for nearly 50 years and use legal and policy strategies to fight discrimination, build health equity, and restore opportunities for people with criminal records, substance use disorders, and HIV or AIDS. In 2017, my team became very frustrated with the criminal justice reform movement because it often excluded any reference to the symbiotic relationship between public health and public safety. Essentially, there has been a lack of consideration or understanding of how the medical industrial complex and scientific racism influence the public safety and public health outcomes we see today. While many initiatives have been underway to reform the criminal legal system in Georgia and around the country, we cannot hope to reverse course without a cross-sector approach that recognizes the relationship between systemic racism, mass incarceration, and inadequate community healthcare systems. In 2018, we launched our No Health Equals No Justice campaign, which is a multi-state initiative envisioning a system of mass decarceration where healthcare is provided to all and people are no longer criminalized for conditions related to their health, like substance use and or mental disorders. The campaign works to address the intersection of historic racism in the healthcare and criminal legal systems, which together make life difficult and disempowering, and too often deadly. I'm sure you've seen some of the concerns that we have for people of color in the US. And the COVID-19 pandemic has illuminated these facts recently. Next slide, please. I hope you all get the slide deck and really get a close look at the images that I've provided here. But there is a history in our country that must be reckoned with in order to ever get to a place where we can achieve equity and make systemic reforms that root out pervasive biases, institutional racism, and systemic discrimination. I'll read off the list of historical events and periods in the United States history that we all must learn about because they continue to repeat or extend into modern times under a new name or image. Attempted genocide of indigenous populations, slavery, fugitive slave laws, Black codes, which were restrictive laws that only applied to Black people, convict leasing, which was an extension of slavery after the Civil War, Jim Crow, which reinforced racial segregation, eugenics, necropolitics, and population control, which derives from the white supremacy ideologies of Thomas Malthus and Francis Galton about who is fit to survive, who is expendable, incurable, unfit, and abnormal. And we are hearing about this history today as we struggle with combating the coronavirus with the new vaccines and trying to address Black people's mistrust of the medical system. And going forward, the building of penitentiaries to warehouse and strip away the personal freedoms of African Americans, prison labor through chain gangs, the prison industrial complex, which spurred privatization and profiteering of incarcerated people, Prison Nation, which describes our warehousing of America's poorest members of society, Then we had drug laws and the war on drugs. So there could be a day-long seminar on any one of these topics, but I'd like you to consider what Kara Page from an organization called Change Frequencies explains about the medical industrial complex that I mentioned earlier. And I quote, "The issue of health equity cannot be addressed without acknowledging that from the beginning of the institution of colonization and slavery, the state has systematically determined who is normal, healthy, diseased, and dangerous as a way of determining access to its rights and benefits." Next slide, please. So due to the criminalization of substance use and mental illness, we have jails and prisons that have been busting at the seams. Communities have remained in distress because people are snatched out instead of being healed and restored within the community. And finally, individuals, families, and communities are ultimately kept in a perpetual cycle of economic and social instability because of the way that we have criminalized substance use and mental disorders. Next slide. So my team always asks, what the hell? Every time we're looking at data related to the challenges that we're dealing with every day and the disparities that exist. We have significant racial disparities in health coverage and health conditions that have been highlighted by the COVID-19 outcomes. African Americans have higher uninsured rates than whites. Black women are at high risk for heart disease and stroke and experience reproductive health inequities. And we also know that health disparities and mass incarceration are inextricably linked. But the correction systems cannot serve as our primary health and behavioral health care provider. Next slide, please. So these disparities, of course, exist in the Georgia Department of Corrections, and I'll reference the correction as GDC, the state correction system. In proportion to their representation in the total population in Georgia, Black people are nearly double its percentage of representation in the GDC. And you heard Laura share some of that information earlier. One thing I have to note is that since the shutdown in March 2020 that resulted from the spread of COVID-19 in Georgia, the Georgia Board of Pardons and Paroles released more than 7,500 people by the end of August 2020 who met criteria of having low-level nonviolent offenses and was within 6 months of completing the prison portion of their sentence. However, they have still left staff and incarcerated individuals in danger because we still have way too many people incarcerated in our prison system, approximately 48,000. And we typically range between 48,000 to 54,000. And I just want to note with some of the data that Laura shared, the reason why Georgia still remains one of the highest rated states with people involved in the criminal justice system, while we have worked significantly to reduce our prison population, we are still off the charts with the number of people who are under community supervision. So we've shifted. Now people are being more surveilled in the community, still not getting services. That's another conversation, but Georgia still has a lot of work to do. And we also know that 38% of the people who are incarcerated in Georgia suffer from a chronic condition that puts them at a higher risk of experiencing complications from the coronavirus. Next slide, please. The GDC does have a COVID-19 dashboard that is presumably tracking the impact of the virus on staff and incarcerated individuals. However, they are not tracking COVID-19 cases or fatalities by race and ethnicity, which makes it very difficult to identify how racially disparate health outcomes are experienced in confinement. Next slide, please. So there are many policies that the Legal Action Center has been promoting to build equity and create opportunities for people involved in the legal system. We want to expand Medicaid. We want to ensure parity between physical health and mental health. We want to build a robust system of culturally effective community-based care. We want to improve health outcomes through greater use of diversion to community care, maximizing Medicaid. We want to effectively link to care and leverage federal opioid and other funding and reentry reforms. We want to abolish systems that use incarceration as a healthcare provider. We want to ensure people currently incarcerated have good access to medication-assisted treatment and other evidence-based care. We want to eliminate historic barriers to the Medicaid program, such as the inmate exclusion, the IMD restriction in Georgia and on the national levels. We want to protect people with criminal records against discrimination by expanding sealing and expungement of criminal records and creating anti-discrimination laws in employment and housing. And we want to protect and expand second chance programs and other essential services and programs that support reentry. And finally, we want to change voting laws to eliminate felony disenfranchisement. So we cannot truly end mass incarceration and all its direct and collateral damage without addressing the health and healthcare disparities that have coincided with criminal justice involvement for millions of people, mostly Black and brown. I hope you will get involved in ensuring that the health reforms we so desperately need in our state will help support efforts to reduce our over-reliance of the criminal legal system. Lastly, we have to care about the fate of incarcerated people. Notice I said people. No one should forever be defined by the worst thing they've ever done. 95% of incarcerated people return to the community, so they are members of our public health system and our society. Thank you.
Thank you, Tony. We have some questions in the chat box for you. So we're gonna take one burning question for Tony, and then we'll come back and try to answer some of those a little later on in the session. So from Brian, regarding diversion, what is the state's investment and commitment to evidence-based diversion strategies to interrupt cycles of recidivism, and to which populations are these programs targeted?
Well, we need to enhance that. Right now, Georgia has a number of specialty courts that have been set up to prioritize certain populations. We have veterans courts, we have some mental health courts. One of the challenges the state is really facing is ensuring that we have enough service delivery clinicians in position to support diversion. But there's a lot that we need to do. And there's also issues about using the courts as the vehicle for connecting people to care and all of the challenges that come with standing over someone with a stick versus providing the care like it would be done in a healthcare setting. So Georgia has a lot to do. Some states have actually committed substantial state funding to setting up the foundation for diversion in their states. Tennessee is one of them, but there's a lot of work to do in that regard, and can definitely talk more about that offline.
Great, thank you, Tony. We are now going to move to a wonderful presentation from our Southern Rural Black Women's Initiative. And again, Tony will be back with us in just a little bit, but I want to introduce you to our next two presenters, Sarah Barbara Williams and Miss Olivia Coley-Pearson. Olivia Coley-Pearson is a human rights commissioner representing Coffee County, Georgia for the Southern Rural Black Women's Initiative. SRBWI is how you might hear us refer to it. She's also a city commissioner for the city of Douglas, Georgia, and she is a mother and an alum of Clark Atlanta, as well as a number of very esteemed leadership programs and recipient of awards. I hope you'll read her bio on our digital program. And we also have Miss Sarah Barbara Williams. She is a community planner, educator, and social entrepreneur. She's a longstanding member of SRBWI team and has played a key role in their asset development and policy initiatives aimed at supporting Southern rural Black women and eradicating the race, gender, and class barriers that they face. Sarah and Miss Olivia, please take it away.
Thank you so much.
Thank you.
GSHF for inviting us this morning, and Tony for your very thorough overview of the historical roots of the injustices that we now find ourselves facing. I'm here with Olivia Pearson, representing the Southern Rural Black Women's Initiative for Economic and Social Justice. We're a 3-state initiative, Georgia, Alabama, and Mississippi. We span 77 counties in the Black Belt of Georgia and Alabama and the Mississippi Delta. And we cover asset development, intergenerational leadership development, policy and advocacy, and human rights for Southern rural Black women. We have human rights commissions, 15 across the 3 states, and Olivia is one of our human rights commissioners. And then we are also engaged in a project with Human Rights Watch, which is a global human rights advocacy organization that identifies and documents human rights abuses and engages in supportive policy initiatives. Next slide, please. I guess next one. We can skip this one too. Okay, so the research that we are engaged with Human Rights Watch is participatory. It's focused on cervical cancer and disparities among Black women. And it's 3 counties in Southwest Georgia, Coffee County, Wilcox County, and Baker County. And let's see. Oh, and I did want to mention that we're in the middle of the research. So if you have anyone who is listening, has connections in those counties, we are looking for women to interview. And that information is on this slide about who to contact. Next slide, please. So as Tony shared, access in the states is a result of neglect, discrimination, and exclusion that is historical and systemic. And in cervical cancer, this has shown up in an extensive project in Alabama, and found that African-American women in Alabama have cervical cancer rates 2 and 3 times those of white women, and are also dying of cervical cancer, which is totally unnecessary because it's one of the most treatable cancers if detected early. And the same in Georgia, that we are now engaged in the research, but similar, we found similar data here as well before we have even gotten started. Next slide, please. So as Tony shared, if you look at any economic indicator, economic or social indicator, you will find that Black communities are on the bottom, and then on the bottom of those are Black women. And so the relevance to COVID is that although we are looking at cervical cancer, and we began the research actually before COVID, and then COVID hit. So we're kind of incorporating some of our research to address COVID issues, but basically the issues are the same. And the most overriding issues that we found are transportation. I can't read my slides. Internet, broadband access, and access to coverage, or being covered. So healthcare. Right. So, and information that includes access to information. So those are the most overriding issues that we have found. And Olivia, when she takes over, will talk about what that actually looks like on the ground. Next slide, please. Again, equity and inclusion, people talk a lot about, and the thing we don't talk about, or maybe the thing that we don't recognize, is that participation, equity and inclusion require both participation and also deliberate implementation strategies. And this is why we began looking at really participatory research as a means of getting at any kind of issue, because when you engage the community in defining the problem and the solution, you're going to get a problem and solution. And I guess I should just mention how these 3 issues are playing out. So the healthcare is basically about coverage, who is covered and who isn't covered. Much higher rates for African-American communities in terms of not being covered. And we have Olivia will go over in the next slide, a chart that in the 3 counties tells you what the percentage of coverages is. And what it doesn't tell you, and what we have found problematic, as Tony also mentioned, is that it's not broken down always. The data is not always broken down by race and by, so it's hard to get at that. But when we do break it down, when we do look into it, we always find that African-American women are on the bottom. And then transportation, of course, in rural communities is a huge issue. It's people don't have vehicles, people don't have driver's license, and the answer to the transportation is increasingly telemedicine, which brings us to the broadband issue. Because there is lack of broadband coverage in rural areas, then telemedicine becomes more difficult to implement. So even our researchers, we're finding we are having huge problems with our researchers being able to have adequate internet access, because we had to make our whole research project digital. So that has been difficult to have consistent internet access. And we can talk, the next slide, please. So the recommendations that we have obviously are Medicaid expansion for the coverage, and access to information is huge. We are finding that with cervical cancer, but also with COVID, that members of communities just simply do not have access to information. Even now with yesterday we had a conversation, and people don't know where to get the vaccine. They don't know where basic healthcare services are, if they are available, and there aren't hospitals in two of the 3 counties where we are looking at in this study. There are no hospitals. So again, transportation, we are looking at telemedicine as an alternative and how to influence policy around telemedicine, and then broadband. And there are some broadband initiatives. There's the Georgia Broadband Deployment Initiative, and you can look these up. The websites are there. We don't have time to go into all of these, but there are billions of dollars now in bills that could be allocated for broadband coverage in rural communities. And some of the issues are that those are going to be up for public auction, and who we are in support of rural electric cooperatives getting some of those funds to deliver the services, because the FCC only requires a fraction of what is actually necessary in terms of speed, 25 MPPs. And to do telemedicine, you need 100. So that there are a lot. If you're interested in that issue, I would say to get engaged with either of those initiatives on the website for more information. And now I'm going to turn, next slide, please. I would like to introduce my colleague, Olivia Foley-Pearson, and she will talk more about what all of these issues look like on the ground in communities. Thank you, Olivia.
Thank you, Sarah. Thank you for that, bringing me on. So I'd like to thank GHF for having SRBWI to come on so that we can bring our findings or some of our findings up as to what we're finding in terms of women's health and cervical cancer. A lot of people don't know it, but approximately between 2013, 2017, Georgia, the state of Georgia had the 6th highest rate of cervical cancer cases in the United States. And Black women were dying at an alarming higher rate than our white sisters. So this is a very much needed research project that we are doing. Alabama has completed theirs. Georgia is currently working on ours. And we are finding that there are so many African-American women who are not getting regular mammograms and pap smears. They do not know about the HPV vaccine, the vaccine that helps to prevent cervical cancer. And that's what we are finding in our research. So therefore, the education is needed, very much needed, in order to change these alarming statistics. So based on race and ethnicity in the state of Georgia, our Latino population is approximately 9.9%, the Black population 32.6%, white population 60.2%, and the Asian 4.4%. In Wilcox County, the Latinos make up 1.4%, the Black population make up 71.1%, whites 27.6%, Asian 0.2%. Coffee County is Latino 12.1%, Blacks 28.8%, whites 58.3%, and Asian 0.9%. Baker County 6.4% are Latino, 44% are Black, 52.9% are white, and 1.2% are Asian. Now, of that population, the median household income poverty level in Wilcox County for overall for the state of Georgia is 58,700 median household income. Wilcox County's median household income is 31,000, Coffee is 40,000, and Baker is 32,000. Per capita income in Georgia is 31,000. Wilcox County 16,841, Coffee County 19,905, and Baker County 22,545. Percent of persons in poverty in Georgia is 13.3%, where Wilcox County has 32.5%, way over the 13%. Coffee County has 20.2%, and Baker County has 24.8%. Access to health care, which is a direct correlation. When you have the poverty level that's so high and you have inaccessibility to health care, you are bound to have many health problems and concerns in those communities. So uninsured persons in Georgia under the age of 65 make up 15.5% of the whole state of Georgia, where 17% of those are in Wilcox, 19.5% are in Coffee, 17.1% in Baker County. Wilcox County and Baker County, neither one of those counties have access to a hospital. Coffee has one hospital. So then when you talk about internet access, like Sarah mentioned, with trying to, if you can't get to the healthcare providers because of transportation problems or what have you, people in these rural communities do not have access to computers and broadband internet. So these are definitely factors that can prohibit or inhibit individuals from getting the adequate healthcare services that they are in need of and the medical attention. So we have got to definitely implement policies and strategies that will assist people in rural communities with having access to, first of all, finances, adequate income. Secondly, or they might run neck to neck, healthcare insurance, healthcare coverage, much needed. And then we must also have access to broadband internet. So pertaining to COVID, what I found here in Coffee County is that a lot of people are being affected. We have high rates of the coronavirus here. So the vaccine is just getting introduced, but then you have people who are concerned as to, especially African Americans, as to whether or not they should take the vaccine because of all the history that has gone on in the Black communities with taking vaccines. And then I've seen, like, we have a local prison here in Coffee County, and I reached out to that facility for them to give me some statistics. However, they didn't get back with me. I don't know if they didn't have the time to get the data that they needed or whatever, but being a resident in this community, I know firsthand the number of people who have been affected, especially in the Black community. And as it has been mentioned, we're not getting that data from agencies that's telling us the percentage of Black people being affected with COVID or within the prison system, because I serve on the city council and I've asked for those numbers, and I'm being told, well, they didn't give us that demographics by race or whatever. So these are some things that we need to know. But I've experienced and seen, not personally in my family, but I know other family members and friends who have loved ones who are employed at the local prison, and some of those loved ones have came into contact and contracted COVID. They went home to their family members and they spread the disease, the virus. And as a result, some family members have died. So it's a very tragic situation that we are in, and having this, presentation, you all doing this is very much needed. We've got to find ways as to how we can get the word out to more people, how we can educate more people, how we can network and interact with each other. For instance, public health and elected officials, community leaders, your churches, your church members, employers, Department of Labor, because everybody is affected. So we have got to implement policy and practices that will address and educate how we can more effectively, try to prevent COVID and cervical cancer and any kind of disease. One last thing that I like to say is that I went out to the local jail the other day because a mother from another city called me about her son being incarcerated. So I was able to get with her and to get in touch with the right personnel so she could go out there to speak with them. And the chief deputy was nice enough to kind of take us on a little tour, and he told us some of the things that they are doing there at Coffee County Law Enforcement Center to try to prevent the spread of COVID. And one of the things he said is that they fumigated, or whatever the term was he used, some kind of way they spray it daily with disinfectant. So I thought that was great. And he said they used a mask. So that's great. That's wonderful. So to keep it down, once the inmates are released from coming back out to their family members and the community spreading it, that's great. So we need policies and things like that in place that's actually implemented, maybe on state levels, to make sure everybody's kind of following the same precautionary measures. But those are some numbers and some facts of things that I'm familiar with that I wanted to share with you all, and I hope that that's helpful. So thank you, and turn it back over to you, Laura.
Thank you, Miss Olivia. That was all really great. And you've got a number of folks in the chat who would love to connect with you all on this research that you all are doing. So we are happy to put you guys in touch.
Okay.
We have some great questions in the chat. Keep them coming, everyone. So we're going to move to our panel discussion for a little bit. And we'll start this question with Miss Olivia and Sarah, but I also would love to hear from Tony on this as well. Georgia has failed to meaningfully include or operationalize racial equity in our state's vaccine plan. Can you share some thoughts about how Georgia and local public health agencies can more effectively engage and work with Black and Brown rural communities to increase trust and to prioritize those groups for the COVID vaccine?
Olivia, you want to speak to that?
Well, I actually thought Roberta would tackle that first.
Okay.
I will say,
I don't know if y'all want me to really do that.
I will just say that I think information is really critical, that people are not getting information. So any way that information can be distributed would be a first step. And then just strategies to get people over that fear and, talk through those with communities, because there is a huge fear of the healthcare system. And there's also discrimination. And we had a seminar, we have a Young Women's Institute, and this summer we had young women talk about the COVID issues in their communities, and they were talking about how poorly they were treated in hospitals and turned away and disrespected. So that there's that also is just contributing to people's fear and anxiety of even seeking help, and then they don't seek help until it's too late.
Yeah, we have a lot to overcome, which is why I kind of walked us through that history. The distrust that our community has of the healthcare system is such a tremendous factor and issue that we're having to deal with right now. And the fact that, as we're hearing, people are still put in these situations where they don't believe that their healthcare provider is working, for their best interest or really values or care about their lives. So I know we'll need to focus a lot more, not just on the information, but really thinking about the messengers.
Right.
And that is a critical factor in bringing about change. And it's interesting because it's a way also that the whole idea around credible messengers, who are the people who are best equipped to go into the community, trusted and respected, to bring the information and have those discussions with people and share the data, is so critical, even in this context around COVID and the vaccine. And interestingly enough, my Congressman David Scott, he just this week I guess it was this week, it's all a blur, but I think it was this week, hosted a widespread conference call and had all these doctors on who shared information about what the vaccine plan was for his covered district, why decisions were made, what people can do, where they can go with the information. And I got on it because I like and I trust him. So, so I think that that's one of the ways that we'll need to do that, and just identify the folks that people in those communities trust the most and engage them in the process.
And I like that. I agree with that. It's very important that we have people going to the communities that they can relate to, because that makes a difference. Like you're just saying, you trust him. And I in talking with people, they're saying that there's a Black doctor, female doctor, who was responsible for helping work to get this corona vaccine where we are, something to that effect. I saw something about a Black female doctor. So some people have even used that. Well, it's been worked on by a Black female doctor. So that's encouraging to some people. So, things like that, that's very important. And I think, public health can use rural communities, strengthen their access and protective factors to work to educate and help to build on and you know, tell people, well, this and that, to give people the facts and the truth. Because once people are given, you know, the facts, they're more apt, I think, to be willing to maybe take the vaccine or either think about taking it. But having people that, you know, like community and faith-based organizations working together, healthcare organizations, I believe we're in a time right now where we really have to all team up and network like never before to get the word out and educate people as to what they need to do and what we can all do to try to slow the spread of this virus.
Thank you. And when we think about trusted messengers and access to healthcare and reducing recidivism, you know, we know that healthcare providers like community health workers and peer recovery coaches, folks like that, can play a big role. Can you all speak to kind of the value of those kinds of I guess we think about them as lay health providers in reducing racial disparities and closing some of those access gaps?
I think with just the participatory research that we're doing, we're seeing the effectiveness of that. When in the interview, we have weekly meetings where we have non-researchers who report back on the interviews that they've had and brainstorm around how to be most effective. And just in the process of having the interview with somebody from the community, talking to somebody in the community, women are taking more proactive stance. We've seen, you know, the researchers have come back and said, because of this interview, somebody who had an issue is now, you know, seeking care where she would not have done that before.
Mm-hmm.
And we're constantly hearing that from the researchers. So it's really, we're already seeing positive results just from conducting the interviews. Which is gets to Tony's point. It is a lot different than if I came in there and said, you need to do this because X, Y, and Z, or you know, it was on the news.
Let me just mention, because I don't know if people are familiar with the term of credible messengers. That's a tactic that has been used to combat violence in the community and to address youth violence. And so it was to identify who are the people most appropriate to go into the community to work with gang members, typically former gang members who were hired and charged with the task of working with folks in the community to address violence and violent activity within the community. So using that, you know, that paradigm of where we're identifying people who are most respected.
Great. Thank you all. This conversation demonstrates there's really a lot of overlap between kind of rural healthcare access issues and you know, justice in the criminal justice setting, or criminal justice and correction systems. But at first glance, they don't seem to overlap necessarily, but they share a lot of the same policy solutions. And I know Medicaid expansion has come up a couple of times today. So can you all talk about kind of where you see the intersections in your work and maybe what are some of those overlapping policy solutions?
Who you want to go first?
Miss Olivia, do you want to start?
Well, they definitely intersect because of the lack of medical health care coverage, the attention, the rate of people can't afford. A lady was telling me the other day that, you know, she was told by the doctor she needed to go and get some health work done about her heart, EKGs or what have you. She went to the hospital. They told her she had to pay $1,400 up front. So, you know, anytime, those are barriers to people getting the attention, medical attention they need. So we've got to find a way to make sure that people are being seen about, whether if they're poor, they cannot afford it. So what do we do? Just neglect them? One family member who just lost a loved one to COVID, they feel like the hospital just kind of gave up on their loved one because the day before the person died, the hospital called asking about their insurance running out. The next day the person dies. So the inequities of not having the health coverage, whether it's due to your level of poverty or where you're located, whatever the reason is. I mean, we're in America. We should not have these situations like this. If people need to be treated and seen about, that's what they should get, regardless if they have the health coverage or not. So there's definitely some intersections between healthcare coverage and, the incarceration rate, all of that. It's all interrelated. And we've got to identify policies, seek out policies that can help to eradicate problems like that.
And I'll jump in now. One of the biggest issues that we have to wrestle with, and I talked about this in my talk, but one thing that was missed, if someone went in to the correction systems and didn't have health challenges, they're almost guaranteed coming out with health issues.
With help.
I have had so many of my ally friends talk about how they may have had some conditions or situations they were dealing with going in but incarceration intensified and made it so much worse. People come out with mental disorders that they didn't have when they went in. People are coming out because of the neglect that they experienced while incarcerated, concerned with health, come out with, and often what we aren't paying attention to, many people come out and within a year after being out, especially if they've been extended sentence, I'm talking 10, 15 years, come out and they barely live a year after that, dying of heart attacks and all kinds of issues. And so one of the issue, the reason why we at Legal Action Center have been fighting so hard for Medicaid expansion in states across the country is not only about, we just want everybody to get some coverage. Yes, we absolutely do. But when thinking about what is happening with folks who are incarcerated, too many communities are not recognizing people in the prison system as part of our community. And when they come out and don't have coverage, people are cycling in and out of the emergency rooms and just routinely using hospitals for care that could have been preventive care, covered and served and addressed very early on. And it's causing a lot of cost issues and killing, and too many people are dying unnecessarily. The other thing is we can use, if we make sure people are linked to coverage immediately upon release, we have a better chance of them being connected to people in the community who care about them and can ensure that they get whatever services and care that they need. And that's an opportunity to reduce recidivism. So we need to do this. And we're hearing so much, I think so much more around COVID, how the countries that have universal health care, everyone has access to health care, they're having smaller percentages of death rates. Like it's not rocket science about why we need to ensure people have health coverage. However, they can't work and get it through an employer, we definitely need to ensure that they get it some other way. So I will get off my soapbox. And yes, that is one of the major issues.
Well, this morning is built for soapboxes, but please continue.
One more issue is that prisons have been used as a rural economic development strategy, particularly private prisons. And so you have prisons that are the primary employer in some of these counties. So you have all the frontline people who are being exposed in terms of COVID, who work in the prisons and then are not properly protected. And then the private institutions are worse in terms of enforcing coverage and care and those kinds of precautions. And rural communities are hotspots. That's another thing that's been proven, just because of the because of the frontline workers coming back into the homes, the same as also formerly incarcerated people who are then released and have nowhere to go. And we had talked about that in an earlier conversation. So that's another big one.
If you guys could briefly touch on how is mental health and substance use showing up in both of your works? And Tony, I'd specifically love to hear from you about kind of how that relates to behavioral health parity, and which is equity in insurance coverage for those of you who don't live in the health policy wonk language. That's a confusing term, but Tony, if you want to kickstart that.
Sure. Concerns about access to mental health services and substance use treatment, that's central and core to a lot of the work that Legal Action Center does in terms of dealing with not only access, but privacy rights, and just ensuring that people are not discriminated against, ensuring that people get access to various evidence-based types of care is another huge issue. And then, of course, the issue of parity and making sure that people are getting the care that they need, and that insurance companies are not treating their condition different than they would treat someone that needed a particular care for a physical condition. And so again, it's central to the work that we do. How it is showing up around criminal justice reform is the issue that we have too many people who clearly have diagnosed mental disorders or have been diagnosed with a substance use disorder and may have committed an offense, end up in our legal system, in the correctional system, instead of being connected to care to try to treat the condition. And so, like many other states across the country and the local jail systems are really struggling to deal with the number of people with serious mental illness cycling in and out of the system and not receiving services, and are trying to figure out what to do, how to do it. And for too long, the data wasn't even being collected. That has since somewhat shifted. Then there's been federal initiatives, national initiatives that have really tried to support local jails and the sheriff's offices and also the state correction systems to set up better data collection systems, and also do better with connecting to clinicians and service providers in the community to kind of streamline the care network, even if it starts with law enforcement and the correction system, but just ensuring that people are getting the services that they need. And so we have a long way to go. In Georgia, there was legislation passed to create the Georgia Behavioral Health Reform and Innovation Commission that is currently examining Georgia's behavioral health system and really looking at where we are falling short, where the gaps in services and care are, and just the whole gamut, and looking at our workforce in the behavioral health sphere, what they can do to shore up and increase the number of providers that are needed in the state. So right now, I think we're in a phase of examining what is, and our lawmakers are looking at ways to address all these huge issues. So they've only just been working together over the last year and receiving lots of information about what other states and localities are doing. Not a whole lot of great details out there, because like I said, there's some demonstration projects and initiatives happening across the country, but really people are just trying to figure it out. Our goal is to just ensure that no one is left out. That's what Legal Action Center is focused on, making sure no one is left out, no exclusion based on type of offense, none of that. So that, it's central and core to our work.
Yes. I'd just like to add in also, I agree, it's very crucial to the work we do. The mother who contacted me about her son the other week, and I arranged for her to get with the chief deputy. Well, later on, she called me when she got back to her hometown, and she was like, he has mental health issues. So I think it's very crucial that staff, whether in the jail, in the Department of Corrections, in the police departments, it's crucial that staff are trained to be able to deal with people when they do have mental health or substance abuse issues. They need to be able to recognize those signs so that the inmate or person that they encounter or whatever can get the proper treatment that they need. So, and I think, you know, a lot of, we've heard in the past about the police shooting and killing different people, whatever. And so a lot of times, if they're not trained to recognize that this person needs special kind of attention, you know, they will not handle that incident properly. So I think we need to have more funding set aside, definitely, to train staff, various staff across all lines of work, to how to handle or deal with people who have substance abuse issues or mental health issues.
Thank you both for that. I do want to move to our breakout sessions, but really quickly before we do that, I want to make sure that I want to ask Tony and Sarah and Olivia, how can the folks on this call and the public health and health advocacy communities generally support your work and help to move these issues forward? What can we do for you?
A lot. You know, and why I'm so excited to participate in this conversation. I started out talking about my frustration with the criminal justice reform movement, but I didn't talk about my frustration with the health advocacy community. I didn't want to come at y'all right from the beginning. So I need us to recognize that all of our work matters. We're fighting for some of the same people.
Same thing.
And so we do need to work together and support each other in each other's spaces in the realm of reform, looking for opportunities to coalesce together. And I'll use this opportunity to talk about in Georgia, the Justice Reform Partnership that focuses on criminal justice reform in Georgia and potentially in other southern states. We'll talk about that another time. But join some of these coalitions, because a lot of your health advocacy work has a tremendous impact on the justice involved population. And if you didn't learn anything else from what I said, just take that one nugget and recognize it. And that there's a role that you can play in supporting a lot of the criminal legal system reform work that those groups are working on, and vice versa. So try to kind of move out of your bubble of work and connect with folks who are seemingly working on issues that you may think doesn't relate to the population that you're looking for, but I can guarantee you it does. And that there's a that you can bring in that space that will be very useful and helpful. So connect to the Justice Reform Partnership. It's right now, the website is 36, oh Lord, they're gonna kill me. I saw Lisa was in the room, or Victoria, can somebody put the link to the website in the chat? That would be great. Like, join the partnership. We meet once a month, and I'm joining a lot of the health advocacy coalitions in order to bring some of the criminal justice reform, but get involved and stay engaged and move outside of your bubble to support the work of other groups. And we have a website about the No Health Equals No Justice campaign. There's a link that you can go to find out more about our campaign.
And I would just say, speaking of moving out of your bubble, prioritize rural communities. Rural communities are so often overlooked. They're not on the radar. They're not on the agenda. A lot of the funding and foundations stay in Atlanta. And Georgia, actually, in terms of rural poverty, is always skewed because of Atlanta. So when people look at Atlanta and they look at all the demographics and the indicators, they think that rural residents of Georgia are better off than Alabama or Mississippi, which gets prioritized for certain initiatives, and we don't because of Atlanta, and then the Atlanta funders don't fund outside. So just paying more attention to rural communities and rural issues and engaging more with us.
Mhm. And I agree with what has been said by Sarah and Tony. You know, we must include everybody. We must be all inclusive, grassroots organizations, you know, the clergy, public health. We must all network. We have to network and educate and come up with a plan.
And Medicaid expansion is huge. Obviously, you all know that.
I promise we didn't pay all of them to say Medicaid expansion, but we're really glad. So we're running a little over on time right now as far as our agenda, but we still have a few minutes for breakout discussions. So remember that our partners at Spectrum Entertainment are going to send you off into the your breakout rooms, and your breakout discussion questions when you get there. Remember, you don't have to press any buttons, you'll get there. What did you learn from today's panelists, and how will you apply this to your work in the next week, and then also throughout 2021.